Good afternoon, everyone. So I'm going to talk on how we are going to improve our accuracy by keeping record of our this outcome, visual outcome, and recording of vision of all patients. So I will start my presentation. So as you all know that today cataract surgery is not just a cataract extraction and IOL implantation, but it has evolved to a refractive surgery. So now patients have very high expectation and they prefer a spectacle-free life. So in Arvind, we have a privilege to have CAT-QA data entry system and that electronic medical record system database where we can record post-op visual vision and we can assess it on a regular interval. So with this data, we can use it for analysis and thereby increase the accuracy and outcome of this one post-op outcome. So I'm going to start with some of our this examples. Like in this table, you can see that there is a 1 month post-op record, visual outcome record. If you record vision of all patient and then categorize into different vision category, like how many patient has gained better than 6.6 or 6.6, and how many patient 6.9 and better, and how many patient have gained better than 6.12, or how many patient better than 6.18, because you know that according to WHO, post-op vision should be better than 6.18 in around more than 85% of patient. So here we can look on that our data that if you capture all the data, then only you can able to analyze on day-to-day basis or monthly basis or 3 monthly basis, so that you can analyze that where are you. So as previous speakers also spoke about that spherical equivalent. Spherical equivalent is also one of the guide of that your biometry, how accurate is your biometry. If your spherical equivalent is better than 90%, so means 0.5 to plus minus 0.5. If it is better than 90%, means your accuracy is good. So if it is coming less than 85%, then you have to look on your biometry whether you are using correct formula or not. So this type of analysis you have to do if you have if you are keeping a record of all your visual outcome. So in this case, you can see that our toric IOL outcome in 3 months, you can see that 6.6 vision is 72% and base corrected visual acuity is 78%. So 93% patient is having better than 6.9. So by keeping record of all data, you can analyze and then you can see. And like post-op spherical equivalent of toric IOL, you can see that plus minus 0.5 diopter of spherical equivalent is around 90%. That means it is satisfactory. So we can learn by some examples. So I will go through one by one few examples so that for better understanding. So in 2015, we introduced one IOL model. So in that, we found that our spherical equivalent was not satisfactory in that. So we retrospectively analyzed the post-op outcome in that spherical equivalent of that IOL. So we found that it was not coming close to 0, and there was spherical error was also coming towards plus side. So in that IOL, we were using a constant of 118.4. So we found that spherical equivalent was not satisfactory in that case. So we started optimizing the A constant, and then we found that using 118.7, that spherical equivalent was close to 0, and spherical correction was also nil. So after this, we optimized the A constant from 118.4 to 118.7. So new constant was used to calculate the IOL power, and then post-op outcome was good. So in second scenario, like about toric IOL, it was in-house inbuilt toric IOL. We found that there was post-op spherical equivalent was not good due to increased rotation of the IOL. So in that case, we increased the overall diameter of the IOL size to reduce rotation of IOL. So, but increasing the diameter of IOL, it shifts the IOL slightly posteriorly. So there was posterior shift of effective lens position. So we need to optimize the A constant to get a good result. So in this case, if you see that pre-optimization of data, when we increase the length of that total IOL size, there was this spherical equivalent was not close to 0. So previously we were using 118.7 in that for that IOL. So after optimizing it to 119.30, we found that spherical equivalent was close to 0. So we started using that constant. So you see that pre-optimization of that A constant, that spherical equivalent was close to 0 in 60% of cases. After optimization, spherical equivalent was close to 0 in 82% cases. So we can learn by our past errors also, how we can improve our accuracy of IOL. So we have so many examples of errors which we review every month in our internal biometry meeting, so that we can improve our biometry. So in this case, you can see that patient presented with mature cataract in the right eye and planned for right eye phaco with acrylic IOL. So pre-op A scan was in the pre-op A scan, axial length was 24.70, and IOL power calculated was plus 14 diopter. In that case, we did B scan also. B scan axial length was showing 22.63 millimeter. Then post-op vision, on post-op visit, the patient was having only 5/60 vision, which was improving to 6/9 with 3.5 diopter of spherical and plus 1.5 diopter of cylindrical power. So where we went wrong? So in this A scan sheet, you can see that in pre-op, that there was gross difference in both eye. Axial length difference was around 2 millimeter difference in both eyes, and IOL power was 14 diopter in operated eye, and other eye it was showing 21 diopter. When we repeated post-op, when we got that surprise and repeated A scan, then we saw that both eye axial length was almost close to each other, and IOL power was also close to each other. So what went wrong? Due to poor visual acuity, fixation was not proper. As discussed, previous speaker also discussed that in mature cataract, you have to look for fixation, and you have to compare with B scan reading, or you have to repeat with other biometry machine, and you can repeat it with two technician also. Like you can see that in the when we saw our data, it shows that both eye axial length shows a difference of 2 millimeter, but A scan was not repeated twice or by two optometrist. And B scan data was also available, but it was not correlated or verified with the axial length of that. So how to improve our this accuracy in a mature cataract? Eye fixation is must. You have to always look for whether patient is fixing or not. You have to put one source of light in front of other eye, so that patient can fix on that with that eye, so that this eye will be fixated on that during a axial length measurement. And at B scan data, you have to verify with B scan axial length also whether it is close to each other or not. And it should be A scan should be repeated twice with 2 machine and 2 observers. Like this is a second scenario where patient diagnosis was right eye post retinal detachment surgery, and both eye was high myopia. So right eye was posted for silicon oil removal with phaco with foldable IOL. So in this case, that phakic IOL A scan was done. Axial length was 31 millimeter and IOL power was plus 0.5 diopter. And patient was implanted with plus 12.5 diopter, which was other eye IOL power, assuming that it is a case of retinal detachment in that eye. And post-op there was minus 10 diopter of surprise in this case. So what went wrong in this case? Like if you see that pre-op A scan and post-op A scan, it is almost same. So there was no error in calculation. Only error in analyzing the case. Like when it was sent to doctor missed the diagnosis that patient is posted for silicon oil removal, not for retinal detachment surgery. So he took A scan power of other eye, and instead of plus 0.5 diopter, 12.5 diopter was advised, and patient was implanted with that, and there was post-op refractive surprise in this case, which we have to take for IOL exchange. So how we can improve our accuracy in this type of cases? Like as Tamilarashi sister also told that in case of retinal detachment, we can take axial length of other eye, but sometimes there will be chances of unilateral myopia also. So you have to ask the history of spectacle use, whether there was difference in spectacle power patient was using, because if you blindly take other eye, that also sometimes can cause refractive surprise. So when we are advising this type of case, we have to look for the diagnosis, we have to look for the finding what was there, and we have to look for difference in both eye axial length, and we have to ask the patient about previous refraction and about spectacle used. This is a third case where it was a case of transcription error, where a patient was diagnosed with mature cataract in right eye, and it was planned for SICS with PMA IOL in right eye. And while doing A scan for that eye, in first attempt, A scan was done only for foldable IOLs, not for PMA IOL. Then patient was sent back for repeat refraction. So in this case, there was also post-op surprise was there. It was 5/60 vision, and it was improving to 612 with -2 diopter of spherical and 1.25 diopter of cylinder. So in this case, like pre-op A scan was showing 22 diopter and 22.53 millimeter axial length. When we repeat A scan of that patient, it was showing 23 almost 1 millimeter of difference was there, and IL power was showing 17.5. So what went wrong in this case? When patient was sent back for a repeat A scan for PMA IL calculation, so instead of putting 23.5 millimeter axial length, the biometrist put 22.1 millimeter. So there was transcription error. So instead of 22.53, it was written wrongly written as 22.53 in place of 23.53 millimeter. So as Shivkumar sir also discussed that how to reduce this transcription error. So when we are transcripting from one machine to other machine, if you are doing axial length with immersion and then transferring data to optical biometer, then you can use this type of stamp, or you can write in the sheet about that axial length, and then you transfer data looking at the instead of just remembering that data and then writing in that optical biometer. So careful entry of numbers and rechecking it twice. You can recheck it that whether you have correctly entered the data correct or not. So this will prevent your transcription error. So these are few examples, but we have so many examples for that in this which we discuss regularly in our biometry meeting to improve our accuracy. So take home message is to ensure correct patient, correct eye, correct optical biometry measurement, correct biometry measurement in advanced cataract where fixation is not proper, and ensure correct biometry in special situation like post-LASIK patient, silicon oil filled eyes, retinal detachment surgery eye. So, and ensure repeat and differing biometry where indicated, where different axial lengths in both eye, K readings in both eyes, and refer to specialty clinic opinion when where indicated, like if pterygium is very flaky and it is causing more than 2 diopter, or if axial length is less than 20 millimeter or 18 millimeter, you have to suspect nanophthalmus, and then we can refer it to glaucoma clinic for planning of case, and ensure correct IOL design, correct IOL power, and ensure correct documentation without transcription error. So there is no learning without mistakes. Thank you.